continuing on with our talks about feeding tubes. The next thing I'd like to talk about is the different types of tubes that go through the skin directly into the GI tract. The first thing I want to talk about is a surgically placed J-tube. This is done in the operating room with a small incision through the skin. It's really the only way that you can get a tube directly through the skin into the small intestines. There are some interventional radiologists that have been successful in getting tubes directly through the skin into the small intestine, but that's very rare. Most of the time when we see a J-tube, it's going to be a tube placed by a surgeon. And just to basically demonstrate, if this is the body wall, basically the tube goes through the skin, directly into the small intestine. The tips of these tubes do not have a balloon on them. If they had a balloon, it would obstruct the small intestine, and anything that comes out of the stomach, including the liter of fluid that the stomach produces every day, would not be able to pass by the balloon. So J-tubes do not have a balloon tip at the end. There'll be red rubber catheters. There are several different types, but they do not have balloons. These are sutured in place typically on the skin to stop them from falling out. The surgeon will also bring the small intestine up to the skin and actually sew the small intestine to the skin. So that's basically a J-tube. When these things fall out, the nurses can put another tube, any tube, a Foley catheter, just don't inflate the balloon, put a Foley catheter or another J-tube or a red rubber tube, anything to get it through the stoma so that it doesn't close. And that's an important concept with all feeding tubes. If something doesn't go back through the stoma within 24 hours, and frequently less than that, the stoma will close and you'll be starting from scratch again. Another procedure will need to be done. So that's basically a surgically placed J-tube. When patients are admitted to Kindred and they have this type of tube in place, nothing needs to be done with this tube to adjust it or change it. It can stay in place. The only important thing is we don't want them to get clogged. So they need to be kept clear. And that's a whole other subject that I'm not going to cover right now in this video. But these things would need to be changed by somebody that can remove the sutures, take them out, and feed another tube in there if they were to become clogged. Other than that, they can be left alone. The next type of tube that I want to talk about is also a small bowel feeding tube, but this type of tube is not placed by a surgeon typically. It's either placed by a gastroenterologist or an interventional radiologist. And this tube that I'm talking about is called a GJ tube. And a GJ tube is a tube that goes through the skin, into the stomach, and then is fed through the pylorus, or the exit door of the stomach, down into the small intestine. Frequently, these tubes actually have two openings on them. One in the small intestine that allows us to feed the small intestine. They also typically have another opening on the tube where it's in the stomach. This allows us to feed into the stomach, but it also allows us to suck out of the stomach. So suction can be applied. So these tubes are really two tubes in one with two openings. And up here at your end, the nurse's end, there are actually two ports. One of them is for the stomach and one of them is for the small intestine. Some of these tubes are held in place by a balloon on the inside so that they don't come out. This balloon, if present, will also have another port that has the typical appearance of a balloon inflating port. Some of these tubes, these GJ tubes, gastrostomy/jejunostomy tubes, do not have a balloon. They're held in with different mechanisms, with a different mechanism. So this is a GJ tube, and again, this can be placed by a gastroenterologist endoscopically, and it can be placed by interventional radiology. And I want to show you a couple of examples of these types of tubes. Surgeons can also place these, by the way, but more frequently they're placed by GI or interventional radiology. Okay. Now here is a GJ tube, and as I described, gastric port, jejunal port, and here's your balloon port. The balloon is inflated, not at the end of the tube, but right here in the middle of the tube. Hopefully you can see that. And And again, that would be holding it in place in the stomach so the patient can't pull it out. Okay? And then this part is advanced through down into the small intestine. Okay? So here's one example of a GJ tube that you may see. And again, I want to emphasize an important point. Frequently we're called because a tube has come out, or a tube is clogged, or a tube is malfunctioning, a tube needs to be changed. One of the first things that we'll always want to know is, does it have a balloon port, a balloon tip port? If it does, then this tube, whether it's broken or cracked or leaking, can easily be removed at the bedside by deflating the balloon and putting a new tube in. If there's a tube that does not have a balloon tip port, then most likely it was placed as the first tube placed in that patient. A lot of those require an endoscopy to remove. They can't be removed at the bedside. And we'll talk about that a little bit more. Another example of a GJ tube. This is one that we use here at Kindred quite frequently. This part of the tube is in the stomach. We then feed a small bowel tube directly through it. The other one that I showed you is a one-piece device. This is actually a two-piece device. We can place this tube and use it as a G tube. We can advance the J tube through it and use it as a GJ tube. This is our standard tube that we place at Kindred, and I want to talk about this for a second. All of these gastrostomy tubes that we have an important characteristic when they are initially placed. And the important characteristic is the ability of the tube to bring the gastric wall, this is the wall of the stomach, up against the abdominal wall. When a gastrostomy tube is placed, the gastric wall has to be brought up against the anterior abdominal wall, and they have to heal together. And that usually takes a couple of weeks. And so when you see these tubes, you'll see devices like this. You're looking at the patient's abdominal wall and you see this external fixation device. Another example of an external fixation device that you would see on the patient's abdomen is this right here. Another example of one is this right here. This will be up against the skin. What's on the inside is either a balloon, or there can be a more fixed type internal bumper. Here's another fixed type internal bumper right here. It's really important after these tubes are placed that there is both an external fixation device and an internal device, whether it be a balloon or a fixed type of a mushroom cap or a button. The purpose of these two, and when these things are placed, they're placed very carefully so that the distance between these two holds the stomach up against the abdominal wall. If this tube is pulled out before this heals, the stomach falls back into the abdominal cavity, and you have a hole in the stomach, and you have a hole in the anterior abdominal wall. That is a stab wound. That's a stab wound to the stomach. You've got a hole through the abdominal wall, you've got a hole in the stomach, and all of the stomach contents leak out into the peritoneal cavity. That's a surgical emergency. Okay? Once healing occurs and the stomach wall is attached to the anterior abdominal wall, which again, the time frame we use is 2 weeks, under that scenario, if this gets pulled out, nothing happens. All you have is a fistula going from outside into the stomach. This does not fall down. The only important aspect with that is if you don't get something back through the stoma within 24 hours and frequently less, that stoma is going to close. So there's a critical 2-week time frame, at which point it's safe if the tube is pulled out inadvertently. Before 2 weeks, it's very dangerous if the tube is pulled out inadvertently. Sometimes you will see, especially when interventional radiology places their tubes, you'll see little clear plastic buttons on the skin with some suture material. Those are called pledgets. And what those do is it's basically a piece of string that has a T piece at the end and the external button on the outside that are designed as a safety measure to hold those two together in case it gets pulled out. These things need to be removed after 2 weeks. So it's really important when a patient is admitted, we need to document on the chart and we need to know, when was this peg tube put in? Because if it's been more than 2 weeks, number one, it's okay if the patient pulls the tube out or if the tube comes out inadvertently. If it's less than 2 weeks, you've got a big problem. The other reason that it's important to know whether it's been 2 weeks is that if they come with these pledgets, these sutures need to be cut, and this will just fall into the stomach and pass. The other thing that's important at 2 weeks, and these you'll see this in my orders, and most gastroenterologists, is that after 2 weeks, we don't have to have that pinching effect anymore. And you guys will frequently see how the skin begins to break down. The skin doesn't like the plastic up against it. It gets moist in there. So after healing has occurred between the abdominal wall and the gastric wall, this external fixation device can be moved back, and this thing can slide in and out. Let me just exaggerate that for a point, just to go along with the picture. Under normal circumstances, when it's first placed, they're being pinched together. After 2 weeks goes by, we want to go ahead and move this back about 3 or 4 centimeters so that there's movement back and forth. This allows the skin to breathe. There's no reason to keep this tight. The other problem is that if the patient gains weight, or especially if the patient is obese, one of the complications of leaving these things tight together is called the buried bumper syndrome. And what that is as you can imagine, if the patient is skinny and now they're getting nutrition with this newly placed G-tube, and they begin to gain weight and their body fat in the abdominal wall gets thicker and thicker, this external fixation device cannot be buried into the skin. It will not pass into the skin. But the internal bumper will work its way into the gastric wall and eventually bury itself somewhere in here. And we have seen that here. And so it's called the buried bumper syndrome. And so it's very important, once 2 weeks has gone by and this has had time to heal, that again, the external fixation device is moved back, allowing this to move back and forth about 3 or 4 centimeters so that we don't get the buried bumper syndrome.